Welcome back. Episode 23.
23.
Is that right?
23.
Of the Full Code Podcast. I'm Ron Dees,
I'm Clint Cloud.
nurse practitioner. You look right into the camera. Break the fourth wall right away.
Yesterday, the last time, if you guys haven't watched it yet, it's the very beginnings. We already talked about this on the last episode, but very beginnings of us trying to incorporate some video as well as the audio, putting things up on YouTube, that kind of thing. So, I don't know. Last time I just intentionally avoided the camera the whole time, but me and you were joking around about the Office thing before. I just saw you glance at it.
I did. I was trying to make sure I was still in the frame.
The Office, and I decided I'm just going to start doing some random gym moments, just looking at the camera.
Well, now
I'm engaging with the audience.
My angle's bad. I can't see out of my screen.
Do you have good angles, Ron?
I do. I'm in it right now. This is my good ear.
Get a good profile.
Well, if you've never noticed, my ears are different.
They look exactly, well,
No.
This one's a little more floppy.
Floppy. Got
floppy
it.
up at the top.
Check. Got it. Thank you.
Oh, man.
So anyway, getting into it here.
Yeah.
So as always, the content of this podcast is intended for educational purposes only and should not be taken as medical advice. Always consult a qualified healthcare professional for any concerns. The opinions expressed are those of the host and the guests and do not necessarily reflect the views of any affiliated organizations or institutions. It is the listener's responsibility to evaluate information, stay current with evidence-based guidelines, and adhere to their institution's policies and protocols.
There you go.
Also,
So listen to us, but don't listen to us.
I'm gonna vent a little bit for a second. I'm really getting irritated
Let it go, big guy.
with this chest situation.
Uh-oh.
I want the information about the exam.
No, I know. I've checked my email all week.
They keep posting about it, and I'm like, tell me.
They said June. They were supposed to put out information, and it's June.
You're over here posting about what did they? Which I did think this was interesting, and I didn't get to look into it. I ran out of time. But have you heard of the advanced practice respiratory therapist?
I saw the post, but
yeah,
I'd heard a little bit coming down the pipe, but I have very limited knowledge on what's that education going to look like? What's the scope of practice? What's the role? How do we see that being used? Is it going to be almost like a plural proceduralist and then advanced ventilatory management, bronchoscopies? I don't know what that all is going to entail, but it's interesting. And especially as a former and potentially still, I don't know if I hold my license any longer.
You don't know if you have your license?
Well, it's a 3-year. I'm not renewing it on the next cycle. So it's either active or it's just relapsed. But as a former respiratory therapist, I still have the bachelor's. But it's exciting for the field. So I'll be interested to see what that all entails.
I'm asking ChatGPT what they do.
What is the...
Performs advanced clinical, diagnostic, and therapeutic roles typically beyond the traditional scope of a registered respiratory therapist. It's designed to bridge the gap between standard respiratory therapy and advanced practice providers like nurse practitioners or PAs, particularly in critical care, pulmonary, and cardiopulmonary settings.
So does it outline what the academic requirements are going to be?
It has not, but it's basically saying you can order and interpret diagnostics, chest x-ray, ABG, PFT, sleep study, initiate management of therapies, NIV, high flow nasal cannula.
So maybe it's just like an advanced certification, and like an RRT does 6 months or a year.
Intubation, arterial central line bronchoscopy, education. Yeah, so it's kind of. I think it's kind of cool in the sense that it's you're trained and if whatever therapies you think this patient needs.
Yeah.
Go for it.
Well, if the advanced practice respiratory therapist is going to get to do bronchoscopies, that just gives me more fuel for the fire because, as Ron knows, I've been pushing hard on the old bronchoscopy thing in the ICU for the APPs at our institution. And, I think we're making good headway. It's just things take time, but that's certainly within the scope of practice of a critical care APP. So. Certainly.
It does say master's required.
Also in the news, for all the millennials out there, Lil Wayne, dropping a new album. Come on,
don't.
You were not a Wheezy fan?
I was back in a minute. Copyright, sorry,
dude. This is our time. Yeah. This is your time to.
We are so back. I remember.
We are so
was
back.
It the Carter 3 or the Carter 4 that came out?
Yeah. Well, this is the Carter 5, baby.
Because the Carter 4
went hard in the paint.
That did it for me. So I pulled a couple other things. I normally delete these. Sorry, Hippocrates, which by the way I love. Shout out to Hippocrates, great app. A little spendy for the premium, but very good app. They have a segment in their emails called Zebra of the Week, which I'd never read, and I want to know if you probably have, but have you ever heard of maple syrup urine disease?
Can you even say that with a straight face? No, I have not.
It's sad because it's a bad disease.
But what is it from Canada?
No. So
did you have the painful urination, dear bud?
Your tinkle smell like
smell
syrup,
so sweet,
bud.
smell like syrup, dear. Put on some pancakes, huh?
Yeah, give her a tug, bud. I don't know if you can say that. So it's also known as branch chain ketoaciduria.
That sounds way smarter.
The short version of it is it's a deficiency of the branch chain alpha ketoacid dehydrogenase complex. And that's responsible for catabolism of leucine, isoleucine, and valine. So you can't get rid of them, so they build up in your system. It's typically it's like a newborn, typical newborn issue. It's usually diagnosed in the first 4 to 7 days of life. It can be diagnosed later. It's called maple syrup urine disease because when these things build up in the system, it makes your urine, earwax, and sweat smell like maple syrup. But it does require urgent treatment, because it can cause developmental delay, all this stuff.
I can't focus on anything medicine right now whenever we're talking about maple syrup
urine disease.
It's just
the children.
It's a great name and it's the worst name at the same time. On that scope of things, I'm a little distracted. Are you like a drizzle of syrup on your pancakes kind of guy, or are you a floating pancake kind of guy?
Drizzle.
Just a whiff, if you will.
Yeah, I want a coating, but I don't want soppy. I don't want it to be too
you don't
soppy.
Like it where it gets a little soggy, like soaked into the waffle?
Well, my thing for pancakes is butter. I want good salted spreadable butter. I want a nice sheen on there.
Okay. So good butter, limited syrup. I guess it's got to be a right ratio.
Yeah, I want a nice top coat.
I grew up in a household where my father was, it had to be in a rimmed plate, because you needed a pond of syrup.
That's exactly what my dad does. He drowns it. Yeah. It's like it's coming over the rim.
Yeah,
kind of situation. He shows up to IHOP and they're like, oh no.
Can you bring 2 more bottles out, sir? That bottle is full. I know. This is preemptive planning.
My dad was also the guy. He was like a big tea drinker.
Yeah.
And he'd roll in and be like, he'd be like, can I have a tea? And they'd be like, yeah. And they bring him his tea and he's like, hey, can you just go ahead and bring me 2 more teas? And they'd be like, seriously? And he's like, I'm going to go through this really fast.
Hey, you know what? I appreciate the preemptive planning instead of finishing your tea, having to wait. It's just I know where this is going. So let's just start from the get-go.
Yeah, let's just get it. Let's get it out of the way now. The other thing I looked at very briefly was the quote, European Society of Intensive Care Medicine 2025 Clinical Practice Guideline of Fluid Therapy in Adult Critically Ill Patients, Part 2, the volume of resuscitation fluid.
More fluids.
So I want you to know what I did. I started to read it and I went, mm-mm. And I plugged it in and I said, can you explain to me what the findings are?
Crystalloid over colloid, balanced crystalloids over salt solutions, conservative approach on fluids. It's like, why we don't need
We're
to
just
keep
beating this to death. So I read it and I thought to myself, this doesn't sound very conclusive. And I said that to
Shocker.
ChatGPT. I was like, am I reading this right? This feels like there's no real definitive. And it was like, yes, your critical appraisal was correct. And I was like, okay. So good thing I didn't spend all that time reading that stuff. Because it basically just ended with
you were sitting there and you were like,
well, no,
I knew it.
It was reaffirming patient-based, patient-targeted IV fluid resuscitation. Consider the individual factors. That's what's going to drive it. And it's just not definitive.
I can't quote you the study, but I printed a study that
That's surprising.
I know a lot of stuff. I just can't tell you which.
If I had $1 for every time you said something about the Cape Cod trial.
That's not true.
I'd have at least $12.
I saw, didn't the Pulm CCM that put something out just recently that the steroids in community-acquired pneumonia was
yes.
potentially harmful. So
Yes.
now there's some debacle about that. So we'll see.
Do you get excited every time there's a new study that says steroids are harmful? Because I do.
Well, I practice more pulmonary medicine than you do. So, I mean, steroids is like the answer for everything.
King of the castle.
King of the castle. King of the castle.
Yeah. No, well, I think it's funny, right? Because we talked about this before. I feel like I'm trapped sometimes in between where, someone will come to me like, why are they on methylpred 60 Q8? I'm like, because someone thought it was appropriate.
Well,
It
we've
wasn't
had
me.
this discussion. I don't think that steroids aren't indicated. I think that they're vastly overdosed a lot of the time. I don't think that pending the clinical etiology, but for the most part, I don't see much benefit beyond 40 milligrams of prednisone daily, depending on the underlying etiology. But most of the time, they're going to get like a 125 Solumed load while they're down in the ER. And then for most things, I do not think people need to be on 60 methylpred Q6 or Q8. Like I think prednisone 40 milligrams daily is just fine. And then in the appropriate context, like a IPF or ILD flare, maybe a little higher, like 60 with a slower taper. But for the most part, I don't not like steroids, but I think I see a lot of over prescription of steroids.
A lot of up titration of steroids is like giving yourself a hug.
Or like people will come in, we get consulted on these COPD exacerbations all the time. And I understand that steroids are indicated, but they'll be on like this crazy high dose. They're not wheezing. They don't sound tight at all. I'm like, tight. I do not think that they need to be on this much steroid.
Well, you're wrong. So
Yep.
I'm just kidding.
Heard
I
that
agree.
before.
I agree with everything you said. That's why we're here. This is the echo chamber. We drink from the same hose.
Incorrect. Before we came on the show, I literally make statements and you just try and contradict everything I say.
No, you say words wrong and I contradict those. Delulululu.
Moving on.
We'll get there. So that's really all I had. I wanted to hit you with the maple syrup urine disease. Also, you said all that stuff about steroids, and now I know, and inevitably someone's going to be like, why didn't you talk more about why the steroids? I'm like, you're going to have to tune in to find out.
Find out next time.
We have talked how many times about doing a steroids episode and be like, nah.
I have a good little mnemonic as far as like straight mineralocorticoid to more corticosteroid and in between. Okay. It's beneficial.
Why do you need a mnemonic?
Well,
do you
to
not know what
remember-
they do?
Well, just to remember which ones are more cortic,
Oh,
like
like the I know what you're saying. Yeah.
high power MD.
Yep.
Yeah.
Yep.
Hydrocortisone, prednisone,
So
methylpred. Dexa.
Anyway.
Okay. GI bleed.
Anyway, GI bleeding. Folks.
That's what we're talking about today.
Why do you keep looking in the camera?
I told you I'm going to keep doing it.
intentional. Oh, please, and also,
I've always wanted to do that.
Obviously,
I'm a big Office fan.
Obviously, we've already put out one video. Really appreciate the support that's gotten quite a few listens. We got a couple followers over on the YouTube. Please be patient. This is not an intuitive process for me. And Clint doesn't help at all.
See this outline here? This is all made by me.
It's just like you can hear just outside of my office, you just hear like bang, bang.
Oh, when you were so ticked off at your computer the other day.
I was pissed, dude. I was about to snap this thing over my knee. I was so mad.
Shout out to Ivy. I'll just say your first name, but saw the first in-person full code shirt walking down the hallway the other day. Brought some joy to my
grandma
life.
was wearing one yesterday. How about that? Let's go. She was like, "That's the most comfortable shirt I've ever bought." And I was like, "You should buy some."
So can we make a formal statement about the quality of the material in the shirt?
think
Because
they
I've
look
gotten a
good.
lot of questions about that.
I've seen
as a
them in
view.
person. I think that they're good. I think it looks good.
People just want to know like the quality of the material, softness.
As far as the
more
V-neck
stiff.
goes, very soft.
Very soft.
Like very soft.
Kind of like your hands.
Wow. right in my feelings. Also, hey, go check out, right? We got mugs now. Did you look at them?
I am purchasing one of those mugs this week, and I
need to know.
pumped on
So
that.
this is what I need to know. I need to know if the QR code is going to be proportionate enough to be scanned. Because I know it works. Because I scanned it on my computer and it works.
Well, if it worked on your computer, then it'll work on
I
the
just
mug.
want to make sure it's not too big and wrapped to distort it.
to where,
you know what I mean?
like the curvature.
Yeah, so I made it smaller, but I was like, what's better than a business card? A business
Right.
mug
Dude,
with a QR code.
you know I love coffee, and having that in the hospital is just going to be clutch.
Also, again, by the way, because I know we had this conversation last time about the markups on prices. When I tried to post that thing, it was like, here, you can sell it for, I want to say it was like $35 or something
For
like
the
that.
mug?
Yeah, and it's like, and you can profit like $12. I was like,
Didn't you
no.
mark it down to like
Yeah, it's
22
Yeah.
or 24 or
Yeah,
something?
it's way down. It's barely above cost, like barely above
We're
cost.
trying to get merch out there, guys. We're actually really not trying to make crazy money.
No. I mean, you need to, because technically this is a business, right? So you do have to make some profit, but it's not, like we said, you're not offsetting any of this.
No.
It's just, it's more about advertising.
Yeah, this is to get us out there.
and see the cool thing. I also just I think it's funny. Like, I think it's really funny to have a QR code on a mug. I've never seen that before, you know?
Well, just so everyone knows, he sent me I'm just quit commenting on it because I'm going to keep looking at the camera. He sent me a picture of it and he goes, look at the back. And you guys don't know how our relationship goes beyond the podcast, but I was nervous to look at the back because I was like, what kind of obscenities or absurdities are going to be here? And then it was just a QR code and it says, listen here. And I was like, oh,
It's going to be a still shot from that video you sent me the other day of you doing some sort of workout thing.
yeah.
And you didn't say anything about the video that I sent you.
Did you send me a video of you doing? Oh, when you were shredding some guitar?
Yeah.
That was sick. I was like driving or going to see a patient at the time.
Yeah. I think I was working on the camera or something, and I was just like sitting there waiting on it to do something. And
Show
then you were texting
ready.
me. Okay.
Here
GI
we go.
bleed.
Yep, GI
Yeah.
bleed.
So the incidence of upper GI bleed.
Well,
I know you have a lot of diagrams and stuff
do.
that you want to talk about.
I do things that I think that are important that Ron does not, but
If the gastroduodenal flexure artery were to bleed,
I did outline the celiac trunk, and I think it is important because whenever we're sending someone to IR, then most of the time I feel like they talk to them and they're like,
bro,
oh,
I think it's the GDA. You
I
got
guess we could take the
GDA.
gastroduodenal. And that's like what it mostly is. But I even was able to list out like where pending location of bleed, what would be the most typical artery that they would probably embolize. I remember learning this, back in anatomy. I remember the main branches of the celiac trunk, but it gets a little bit more nuanced, obviously, as it goes into things. But then I did outline just kind of like the splanchnic venous outflow tract.
Splanchnic.
Because we'll talk about portal hypertension and variceal bleeding, and I think that was also important as well. So
Yeah, so just for clarity's sake, right, we're going to talk about upper and lower GI bleed, but like 90% upper. Because lower GI
I even
bleed
wrote
is like,
down here, which I found, I guess just seeing a number was like a good thing to see. I know anecdotally from experience that when we're dealing with a massive GI bleed, hemorrhagic shock situation, it's almost always an upper source. But right here, upper GI bleed, 80% of ICU cases of acute GI bleed are going to be an upper GI bleed. Lower GI bleed, much smaller predominance, and there's limited things for us to do from an ICU perspective anyways. So most of the time that we're getting an admit to the ICU for, hemorrhagic shock, massive GI bleed or hemorrhage is going to be from an upper source.
Yeah.
So I know people love the hemodynamics, and we love hemodynamics.
I was going to say something about that because I saw it and I was like, do you really need to explain the pathophysiologic response to the acute blood loss?
I think we do.
Before you get too far, I added a second incidence of. Okay, that's what we're doing because you just had mentioned like the incidence for upper and lower. I added on to that, which is 10 to 30% of all upper GI bleeds require ICU admission, and 10 to 15% of lowers require ICU admission. And then I have a bunch of breakdowns of what the incidence for each of them is. I feel like this is very.
That's my breakdown.
Stop it right now. You're fired. All right. Sorry to interrupt. Go ahead and explain what the body does when it hemorrhages.
Are you not going to do the breakdowns?
Oh, do you want me to do the breakdowns?
Yeah.
Okay.
Yeah.
So I have it broken down by etiology. For the upper GI bleed, you have that accounts for 35 to 50%. Peptic ulcer disease accounts for 35 to 50% of upper GI bleeds in the ICU. That carries a 10 to 25% mortality. Esophageal varices, that also includes gastric varices, account for 10 to 30% they carry a 20 to 40% mortality. That number gets a little shaky though, because that, it comes with an extremely high rebleed risk. And with each rebleed, that increases your mortality.
Right. Is this variceal bleed the sentinel bleed, or is this a rebleed is going to drastically alter the mortality?
Your Mallory-Weiss tear, so that's a 5 to 10% incidence, but less than 5% general mortality, rarely requires ICU. We'll cover what that is. Erosive esophagitis, 10 to 20% incidence, 10 to 15% mortality, but that is a little questionable in there. The Dulafoy lesion, 1 to 2% incidence, 15 to 30% mortality because it's an arterial bleed.
Yeah.
And then stress-induced mucosal
big
disease, big 5 to 10% incidence, greater than 30% mortality. But again, that's variable how you define it, kind of. I did lower GI bleed, but across the board, even though so for example, right, diverticular bleeding is the number one, would be 30 to 50% incidence in the ICU with lower GI bleeding. But as we talked about, you're talking 10 to 15% of lower GI bleeds go to the ICU. Very low, typically can be managed on the floor. But I'll just give you the list. I won't go through the numbers. It's diverticular bleeding, angiodysplasia, so AVMs, ischemic colitis, colorectal neoplasms, radiation, proctitis, and post-polypectomy.
You didn't even put hemorrhoids in there?
I hate hemorrhoids. Piss me off. Let me go straight there.
No, I know. That's why I was
piss me off, because the amount of times
I was kind of poking the bear.
People are like, oh, or like, it can be anybody.
It's bright red blood.
There's bright red blood. Okay, can you describe it to me? Yeah, it was streaked over my poop. So is it in
It was
your poop?
on the paper when I wiped.
It was on the paper. Well, you're going to need a stat colonoscopy right now.
Does your toilet look like a massacre situation, or is it just like
let's go ahead
a couple of drops?
Let's go ahead and jump to the front of the line. If you haven't assessed your patient's butthole, don't call GI.
Well, I feel like a lot of the times they're internal hemorrhoids because the patients don't have it. It's not painful. They're not thrombosed.
Yeah.
They just have like maybe a little bit of mucousy, bloody stool. Mm-hmm. Yeah. Anyways, I'm with you.
Yeah. So,
especially in your elderly population.
There's your clinical pearl.
Assess the butthole.
Perform a physical examination in the posterior rectal
vault.
It's not in
the rectal vault.
It's not in the vault. It's at the sphincter.
All right.
The vault is where I keep things. all my
people
dreams.
Have used it for such things before.
Is that why they call it the prison wallet?
Yeah.
We should open with this one's not as family friendly as the other ones because it's all about poop and butts.
We're kind of sliding downhill here.
Listen,
bringing it back.
Bringing it on back in here. One more thing before you go. I got some general mortality stats. Generally speaking, upper GI bleed carries a 2 to 10%, and lower GI bleeds like 2 to 4%. The mortality signal increases significantly with ICU admission. It generally triples right off the bat. And that's how you get the 15 to 30% jump, and then the 10 to 20% general jump. Those are generalized numbers. Thanks.
You're welcome.
Big numbers guy.
Big numbers guy. like those statistics, do you?
I want to know if you're going to talk about the crura of the diaphragm today.
I'm not.
Okay. Carry on then.
Are you?
That's on my list.
Okay. So typical hemodynamic response. I think this is self-explanatory, but I wanted to outline it, right? Because I think that any type of repetition is good. These cameras are a problem.
I know.
It's fun though. All right. So you get decreased effective arterial blood volume, right?
Mm-hmm.
So that's going to reduce the preload, which is going to consequently decrease your stroke volume. Cardiac output can result in hypotension, right? You're going to have a compensatory tachycardia, and compensatorily to increase your blood pressure, you're also going to cause peripheral vasoconstriction to increase your systemic vascular resistance to try and maintain your blood pressure. That is all sensed by the baroreceptors, pressure receptors within the body, carotid sinus, also elsewhere. They sense that. They increase sympathetic activation, epinephrine and norepinephrine, released from the adrenal reticularis, causing systemic vasoconstriction, increased TPR, SVR, increased heart rate, increased cardiac output, and a therefore stable blood pressure.
Blood fall out. Body realize blood fall out. Make veins squeeze. Heart pump. Perfuse brain.
Nailed it.
Nailed it.
All right. So that's just your basic hemodynamic response.
Thank God.
So it's important because if people are taking advanced testing, I outline this stuff. If someone's studying for the CCRN, whatever the case may be, the critical care specialist in respiratory therapy, there's going to be advanced hemodynamic questions. And a lot of these are going to, if they give you Swan-Ganz catheter values or CVP or TPRI or stroke volume or cardiac
Which they
index,
do. They give you
which
all
they
those
do.
metrics,
So
yeah.
beyond making fun of me, this is pertinent information, especially in a testing situation, to know how different types of shock are going to have different types of hemodynamic response. And so that's why I outlined it. You are welcome to our listeners.
That'll be our one day when we work up the courage to do an advanced hemodynamics course.
I'm ready.
I'm ready.
So risk stratification, you can use the Glasgow-Blatchford score or the AIM-65 for upper GI bleeds to essentially...
Oh, you're jumping straight to scoring.
Well, just kind of how they're going to present. You can use these scorings on presentation to kind of predict severity, risk of mortality, outcomes, that kind of stuff. To be honest with you, this was something that you had gotten pimped on recently by one of our providers.
You got pimped on, and then I got pimped on by consequence.
Oh, okay. Well, I was unaware of some of these risk stratification.
Do you want to know a
scores for
secret about
upper
that
GI
pimping?
bleed. Were you Googling it at
Yeah.
the same time? You mother trucker.
So it was really funny because I was legitimately doing something else, and I heard it, and I was like, "Oh, I'll just look it up because it's something I'd want to know."
So then when he asked you,
And then
you
he
got
asked
it
me, and I
right?
said it, and then you like, "Did you look that up?" And I was like, "No, look." And then as soon as it was over, Amber was right behind me, and I turned around and I said, "I definitely Googled that," and she was like, "I would have too." Nice. You can't lose them all, baby.
So when I went home and cried about that, how dare you? All right, you want to talk about typical presentation?
You're either throwing up blood or you're pooping blood, or both.
Yeah,
There you
and
go.
it can be coffee ground, or
There
it
you
can
go.
be bright red, or it can be melanotic and more maroon
Yeah,
colored,
so
or
I-
it can be bright red.
Yeah, and that's kind of one of the cues, right? Because if you're, when people say I have blood in my stool, right? An important question is it bright or is it dark?
Yeah.
Because that tells you where it comes from, generally speaking, where it comes from. I think maybe, I think you'll probably agree with me on this. I think one of the more important parts of this is not necessarily what's happening. Like that's a pretty cut and dry situation. It's more the history
Right.
behind it. Like we want to know, is this patient a drinker? Are they a cirrhotic? Da-da-da-da-da. Like, do they have a cancer history?
Smokers.
Have they had a GI bleed before? Are they on a blood thinner, right? Like the history is very important.
Lots of NSAID use.
Yeah. Well, that's one that definitely flies under the radar. I think a lot where, we've had a couple recently where it was from NSAIDs.
Yeah.
Where we just checked in. We're like, oh, do you drink? Do you?
No,
know?
1,000%.
And they're like, no, I just hurt my knee
Shoulder,
and I've
knee.
been banging ibuprofen for
Yep.
a while.
Yep.
And it's like, oh. And then it's like, I feel like we've covered this so many times. Why don't people know?
I do still ask a lot of the questions that are, they are textbook questions, but I mean, it's pertinent. I ask if they're a smoker. I ask if they've had a GI bleed before. Do they take NSAIDs? Have you, do you have any known bleeding disorders? Are you on a blood thinner? Like all that is pertinent information for trying to determine etiology. Now, you can take a great physical exam. You can ask some questions. There's always the ulcer question of if it gets better with food or is it worse after eating, or when do you get relief, and you can try and ascertain, is this a gastric ulcer or a duodenal ulcer? Ultimately, all of these are going to need endoscopy and direct visualization.
I was like,
right?
that is internal medicine gobbledygook. We're calling GI. We're getting a scope in there. I don't need to
ultimately,
know.
well, I remember learning all that stuff to try and ascertain which source of bleeding you have. But I mean, guess what? An EGD can look in the esophagus, in the stomach, in the duodenum.
Proximal duodenum. Yeah.
So you're going to be able to visualize it also. Biggest thing is,
you said duodenum?
yeah, I wanted to see if you caught that.
Golly.
We had the discussion beforehand if we were going to, if he called it the duodenum or the duodenum.
Yeah.
I'm going to switch back and forth just to irk people's nerves.
Is it caramel or caramel?
Caramel.
Pecan or pecan?
Pecan.
Get out of this room.
You say pecan?
I don't have it.
Pecan. I have a pecan.
That's just going to be the go-to now.
The comedic relief this episode is
It's
on point.
They're going to be like, just shut up and
talk about GIB.
Just tell me. What was I going to say? Yeah, no, that's actually a really good point in the sense of, yes, all those things are true. But from an ICU perspective, it's just like, think about the scenarios when we get called.
Right.
They're either already intubated because of, typically it's an airway protection issue. Or you go down there, you talk to them, they've had a hemoglobin drop, but they're stable, and the GI is either going to come up and scope them, or they're going to say, okay, will you intubate them so I can scope them? I'm a little concerned. And some of that's from history, some of that's from volume, some of that's just personal practice and what your level of courage may or may not be.
So I list that stuff. I say that stuff, just like I said, the hemodynamic response. Is it important? Like you said, from an ICU perspective, they're going to come to us. We're going to do what we need to stabilize them. We're going to consult GI. GI is going to take a look. Hopefully they can fix the problem.
When I would say this, right, there are things that do matter to us, right? Like we had mentioned, if you're, because I've been asked this a lot, people often say like, and this is in the realm of what I would call temporizing treatments. I think that's a safe way to say it. But they'll ask, why do we put some people on octreotide and some people on pantoprazole, right? So we'll talk about that a little bit. But that's case in point. If you're a bleeding cirrhotic, then, and we're concerned that you have varices, then octreotide is going to be very appropriate.
For sure.
But you won't necessarily, and we will break down the pharmacology and why. But like even with pantoprazole, right, you can't really go wrong with, if you don't know, just do it.
I think that pantoprazole is just the reflexive, again, sorry folks. We just outlined that
biscuit eater.
We can ask all these questions, but you may not be able to ascertain, obviously, without looking what exactly is the cause and or source of this GI bleed. So the safest bet is to start the appropriate therapies based off of your clinical suspicion and patient's underlying comorbidities. And then as you discover the actual cause of the bleed, you peel back therapies.
Yeah. And I think, I don't know. I don't know what you would say about this, but I feel like generally speaking, there's not a lot of surprises. Like we generally know, like, oh yeah, this person's got varices. Oh yeah, they're a cirrhotic. It's a pretty rare bird that we're like, oh, you might actually have a varice, right? So initially, when you're looking at the treatment algorithm, it's ABC is first and foremost, right? So make sure your airway's secured. Make sure that you have, if your patient is bleeding and they're hemodynamically compromised, you need to initiate MTP right away. Yeah. And then there was another point there I wanted to make.
Well, we obviously don't want to cause a worsening anemia by hemodilution, but I mean, obviously the treatment for blood loss is blood, but in the event of massive GI bleed, you're going to be slamming in blood products, but you're always going to be resuscitating with, balanced crystalloid solutions as well in the interim while you're trying to, because what's the problem here? It's all intravascular volume loss.
Well, that's the thing that gets under my skin is when the patient's thrown up blood, they've not been adequately resuscitated, and now
Let's put them on some Levo.
Yeah, they're on Levo now, and I'm like...
And quite honestly, I mean, not to go down any tangents, but whatever problem this patient has, we may be precipitating other problems like ischemic bowel, ischemic colitis, AKI, other ischemic organ injuries, ischemic hepatitis, yada, 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 because they don't have the effective arterial blood volume to perfuse their body anyways. That's why they're hypotensive. And then we put them on, a vasoconstricting agent, and we even limit that blood flow even further. Like if you squeeze on the arteries, good, but you need to fill them first to support blood pressure. So,
and you need to lower your blood pressure goal a little bit,
right?
Because you don't want to especially if you're concerned you got a leaky hose.
That is a great point. I should have looked that up. You may be able to look it up right now, but I mean, in a post bleed patient, right? Like, what if they have some rebound we over resuscitated this patient? They've got hypertension at a baseline. Now they're nearing, shall we say, TACO or TRALI, or let's just say TACO, transfusion associated cardiovascular overload. And you target a higher blood pressure. I mean, you're increasing the risk of rebleed by having this real high mean arterial pressure and systemic vascular pressure. I mean, you're going to put them at a higher risk for rebleed. So just as we, need to pay close attention to blood pressures in stroke patients post thrombectomy or post embolectomy or post TPA or post coiling, I mean, I think that's a good point, that you need to be paying a closer attention to your hemodynamics, not just in the sense of maintaining a good perfusion pressure, but not allowing too high of a blood pressure.
Avoid over resuscitation.
Yeah.
So it says an uncontrolled bleeding target SPP greater than 90, MAP around 60 to 65. After hemostasis has been achieved, SPP 100 to 110 in a normal MAP.
Yeah. Okay. I knew it was lower than, you could be like, 130, cool. But, again, it's nuanced things, but it's,
how many times
good clinical management.
Somebody bleeding in their belly, and then we're hammering them with pressors.
Exactly.
And then their systolic's 150 and their belly's getting bigger.
Right.
And bigger.
That's my whole
bigger.
point. Yeah.
Yeah. These patients, it's a wide array of presentation. Could be, hey, I've been throwing up blood a couple times at home and now my hemoglobin's dropped 3 points. Yeah. Versus like, oh my God, there's a blood fountain coming out of your mouth and I have to intubate you, and then you have to have a what do they call it, a Sandstake Blakemore tube.
And it goes kind of without saying, right? If a patient comes in with a hemoglobin of 5.5 or 6, but they're either hemodynamically stable or they're not hypotensive, they have a marginal, they're soft blood pressure, but they're mentating well. They're not dyspneic, they're not having chest pain, their urine output's okay, all the signs of good peripheral perfusion are intact, then this may be an oozing ulcer. They have a GI bleed, but this isn't a sentinel like massive hemorrhage. And these patients probably aren't coming to the ICU, right? But
well, and especially in, as we mentioned, the cirrhotics, right? They can have diffuse microvascular bleeding. Even just from like gastric mucosa,
that esophagitis, that gastritis, that's just kind of a slow ooze.
So everything's context dependent, right? If a bleed is severe enough, they're going to get intervention in the emergency department. Like it's going to be pretty rapid. I would say that's probably the minority of them. We typically take them and have an EGD within 12 hours, which is the goal.
Good resuscitation and stabilization occurs in the ER, but generally intervention occurs in the ICU, at least at our institution.
Yes, typically. It's got to be bad. Like you got to be raining blood.
Yeah. I mean, not that it doesn't happen. I've seen EGDs done regularly in the ER, but...
Well, and that's like, where the gastroenterologists, they have a different threshold for those things where they're like, it's fine.
Yeah.
I'll be there when I get there.
But it's a tough situation as the intensive care provider. I know you've been in the same situation. It's always on nights. You always end up with this massive GI hemorrhage. And most of the time, GI's already seen the patient. They've already scoped them. They either couldn't find anything or they clipped something. They're bleeding again. They're like, we've already scoped them once. They need to go to IR. IR's like, oh, GI needs to scope them again. And we're stuck in the middle is the resuscitationist and the ICU provider because we can't perform any intervention. So we're like, I'm doing what I can medically. I'm throwing blood products in them. I'm resuscitating them. We're starting other appropriate therapies, whether it be octreotide, vasopressin, yada, yada. But like ultimately, you've got to advocate for your patient. So I've had situations when I was working on nights where GI, to their credit, very agreeable. They had already been scoped, but they're like, I'll come in, but my confidence in success is low. Why don't you go ahead and call IR? Called IR, told them the story. They're like, okay, well, if they don't find anything, send them to us. They ended up having to go. They took the gastroduodenal. Luckily, that patient was stabilized, but it's a hard situation to be in because you're at the bedside because this patient is clinically deteriorating. They're hemodynamically decompensating right in front of you, and there's nothing that you can do to fix it except for just trying to stay on top of things. So.
Yeah, that is one of those. I don't want to say you feel powerless necessarily.
No, I mean, seriously.
But you do have to have like a, you do have to work, especially in the cirrhotics. You got to work a little bit of nuance in there.
Yeah.
Because we've talked about, and we're absolutely not uncorking this on this episode, but the idea of how to manage a bleeding cirrhotic.
Yeah.
And it's like,
It's a lot.
because as we've talked about, we have a wide array of practices, and sometimes we are aiming for really high fibrinogen goals and, really optimistic INR goals.
Yeah.
Or, IR wants to be like, I need you to get there.
INR less than 1.9.
Yeah, and you're like, that literally isn't going to happen.
Not going to happen.
There's not enough vitamin K in this hospital to make that happen. So, so we talked about, obviously, endoscopy is the end point. We talked about, hemodynamic stabilization, resuscitation, MTPing if you have to. You had mentioned making sure you're getting appropriate fluid resuscitation. And, that applies into, so like my general rule of thumb is if you're still hypotensive with a normal hemoglobin at this point, then you can move to fluid resuscitation with some vasopressor support, but low with the lower, targeted goal. And then I think we want to talk about pharmacologic therapies.
I just want to, can I say one quick little pearl?
Yeah. You don't need my permission, dude.
To your point of if they have a stable hemoglobin, but you know that their volume deplete, you're giving them fluids. I think we all know this, but again, I'm just putting it out there just for those that don't know. If your patient comes in and their hemoglobin is stable, at least from the critical care literature, it's not less than 7. I'm not going to go and do the whole 8 if they have a history of coronary disease, or 9 if they have active ongoing chest pain, yada, yada. We'll just say 7. You guys can look that up if you want to on your own, but they do have recommended different transfusion goals given patients' coronary status. But
see that chest up them a little bit?
Yeah. Like 10.
Yeah.
I did see that. But if your patient has a hemoglobin of 8.5 and they have a massive melanotic stool and their blood pressure is soft or they're hemodynamically unstable, don't wait for the hemoglobin recheck. I don't care if their hemoglobin was 8.5. They just had a massive melanotic stool or bleed. Whatever source that's coming from has not been fixed yet. You need to transfuse them now. If you wait, you're going to get behind the 8 ball, and then you're going to feel like you're just trying to play catch up the whole time. So, clinical gestalt as well.
Yeah, that's actually a really good point, and that's something that I've kind of had to learn, because it's not like, it is common sense, right? But it is a little bit nuanced, because you need to come out and evaluate the situation yourself.
Yeah.
Like, I get called all the time, like, oh, the patient had a large bloody stool. And I usually come to try and look at it, or at least get a clear answer on about how large it was. And then, like you said, kind of shoot from the hip, like just go ahead and empirically transfuse them. We had mentioned we're going to cover 4 medicines, but the first 2 are the mainstay, the pantoprazole and the octreotide, right? So, like I said, people often ask why this, then that, blah, blah, blah. So pantoprazole right away. So how does pantoprazole work, right? It inhibits hydrogen potassium ATPase enzyme, and those are in your parietal cells, and that essentially halts acid production. Not completely typically, but it's going to really, really dampen it down.
It's on the luminal membrane.
Yeah. But why, right? Because acid impairs in clot stability. That's a big portion of it. So when you have all this acid in there, you're not going to have good luck forming a clot or stopping that bleed. The rest of it is kind of like maybes. So definitively it does reduce the risk of rebleeding and the need for surgical intervention. It might decrease mortality, but that's only if you couple it with endoscopic therapy and that signal still isn't clear.
Well, into everything that you've mentioned on point, but just in a simplistic manner, right? Like, you're trying to maintain a mucosal barrier, right, within your GI tract to protect it from this strong gastric acid that's needed for digestion and what's the word I'm looking for here?
Not gonna help you. Figure it out.
Sterility. I don't know. It can help prevent.
Keep going. You're gonna find it.
Bacterial overgrowth.
There it is.
Those types of things.
Found it.
I was trying to think of a better way to say it, but you get what I'm saying.
Yeah.
So, by impairing this excessive acid production, you're therefore trying to also protect the gastric mucosa from further degradation. Because if you have this really high acidic content, it's just going to try and erode and degrade that gastric mucosa even more. And so if you have, say, a bleeding ulcer and you have impaired gastric acid or basic secretion, and you impair that protective barrier, and then you have this excessive acid production, it can just kind of propagate the problem. So that's also an important point of that.
Yeah. My last point on pantoprazole is this. Dosing wise, 80 milligrams right off the jump. So give them a big bolus. 8 milligrams per hour continuous for 72 hours. Now, obviously...
Are you drip versus just scheduled push guy?
If it's bad, I'll take a drip. I will often...
I don't think if you dove into the literature, I have seen that 40, the initial load, 40 milligrams IV, BID is not insufficient comparatively to a drip. However, I don't think either one is wrong. I'm never going to be like, oh, why'd you put them on a drip, or why didn't you just do this? I'm just nitpicking nuance. But
I don't necessarily think that there's a right or wrong answer there. And as far as I'm aware, the literature doesn't indicate that either. Yeah. And I would say empirically that we're doing more BID pushes.
Is it probably easier to just put them on a drip?
Yeah, for sure. For 72 hours.
For 72 hours.
And the GI doc may say, hey, it's not necessary. Hey, you can do this. That's fine. But that's the general recommendation.
And then pending their findings, they're going to dictate duration of therapy.
Yes.
Afterwards, taper, follow up in the clinic for repeat EGD and so much time.
And again, this is something that does, again, it kind of, it's I don't want to say spirals out. That makes it sound bad. But and for example, in the setting of a bleeding cirrhotic, your pharmacology moves from this to do they need to be on a beta blocker? Do they need to blah, which is not for this episode. Our other med, octreotide, which comes up a lot. So octreotide, the shorthand is right. Octreotide is if you suspect that there's cirrhosis.
Right.
You either know it or you suspect it. Your octreotide essentially decreases portal hypertension, right? It's a somatostatin analog. It's going to constrict your feeding vasculature to reduce your bleeding. It's a temporizing measure for, a pending endoscopic intervention, and early use improves hemorrhage control and reduces rebleeding risk.
Yeah.
So somatostatin inhibits the release of vasoactive gastrointestinal peptides, which lead to
vasoconstriction or vasodilation is what you're talking about, right?
Yeah, when we use it, it leads to vasoconstriction, right? Vasoconstriction. So that is a 50 microgram IV bolus started with a 50 microgram per hour continuous infusion for up to 3 to 5 days.
Can I please give a 30-second outline on cirrhosis and portal hypertension?
Yes.
Okay, because I love this pathophysiology, and we'll talk about it more in potentially a battle renal syndrome episode sometime. But so when the gastric outflow is trying to go through the splanchnic circulation into the portal vein, through the liver, up through the IVC and back into our systemic circulation, it's got to flow through the portal vein. And if you have cirrhosis and this fibrosis and nodularity, then it causes increased resistance to that outflow, right? So you're going to increase portal pressures. I mean, that's pretty straightforward, right? But what does your liver and splanchnic vasculature do in response to that? When it senses this increased resistance to outflow, it releases vasodilatory substances to try and vasodilate that splanchnic circulation and therefore the portal vein and improve the flow through the portal system. So you get this kind of almost excessive splanchnic vasodilation to try and compensate for this portal hypertension. And in so doing so, this is one of the things that can cause cirrhotics to accumulate ascites and things like that, just because you have increased hydrostatic pressure. And then with vasodilation, you get some of that endothelial cell separation. And then the hydrostatic pressure causes, extravasation of plasma and fluid into the peritoneal space. But that's kind of pathophysiologically what's going on. So that's why you have this excessive splanchnic vasodilation. Yeah. And then in addition, the failing liver can't metabolize some of these vasodilatory substances that are released.
Yes.
And so you get kind of this snowball effect of this vasodilation.
Yeah.
And so my whole point to that is that's why octreotide, in the past vasopressin, or things that cause more splanchnic vasoconstriction, are trying to reduce those portal pressures and therefore the bleed.
Yeah, and that's also the root of your variceal formation.
Right,
in that
exactly.
When you have all this pressure, right, you get neovascularization, you get collateralization. Your body's trying to offload that pressure. And you know, to your point about the toxins, right, part of that offloading is creating essentially paths around the liver,
right,
and that dumps into the distal esophagus.
Right.
And then there's the submucosal veins of the distal esophagus.
Yeah, interestingly, while we're talking about it, I didn't realize, because I looked it up, the coronary vein is one of the veins that is giving venous outflow from the distal 2/3, and that's what I always learned. Interestingly enough, I don't know if it's more than the distal 2/3, but there are varices that form in more of the mid esophagus, but they're more submucosal, so they're not like you don't see them. They're not as prominent. They're protected more so by that, mucosal and muscular layer. As you get more distal, they're more luminal, shall we say, or just, very peripheral. And so that's why those vessels are the ones more prone to bleed and all that kind of stuff. And then just gravity too, right? I mean, the lower are going to have higher pressures. So
Gravity's not real. I won't talk about this, but I just love the flat earthers who talk about how gravity's not real.
I love when the flat earthers come up with an experiment to prove the earth is flat, and then it's proves the earth is round. And they're like,
clearly there's variables we didn't get. Yeah, the variable is that the earth is round.
Yeah.
That's octreotide. That's pantoprazole. I wanted to touch on ceftriaxone.
Okay. 1000%.
Especially in bleeding cirrhotics, right? Bleeding cirrhotics.
Well, let's be honest. I mean, really only in bleeding cirrhotics, right? Like if you come in and there's zero concern for a variceal bleed and you don't have a history of cirrhosis, and you have a GI bleed, I'm not going to give you Rosefin.
Yeah. Well, and this is one of those areas too where I would heavily promote antibiotic stewardship. Yeah. So have a really good reasonable suspicion to or to not. You can make the argument like, well, it's the one dose of ceftriaxone going to do. Yeah. Sure. But we try to be judicious clinicians, right? Yeah. So your bleeding cirrhotics, they have a high risk for the development of spontaneous bacterial peritonitis. And so this is a multifaceted problem. The first is obviously you have an infection that could be life-threatening right off the jump. Two, bacterial infections in this setting can increase portal pressure and precipitate rebleeding. So if you have any suspicion, that's bad. This is a formal recommendation from the American Association for the Study of Liver Disease and the Baveno 6 consensus guidelines. Did I read them? No. But I did write that down. Mechanistically, ceftriaxone inhibits bacterial wall. You know what I'm saying? I just dumped right out.
I don't know.
It's going to stop your bacteria from protecting itself from the rest of the world, and then it dies.
Well, and to your point that you made earlier, when you get this revascularization or collateralization around the liver to help support this increased portal flow, you just said that the liver, that's already impaired, but those toxins that would be clearing, would shunt into the systemic circulation. Yes. So if you guys remember,
don't do it.
GI bleed is a strong precipitator for hepatic encephalopathy in these cirrhotics. So
you remember the pressure within the portal system. Your ammonia.
I did talk about portal pressures and when you're at increased risk of bleeding, and you have to measure them in a very invasive way. So I didn't talk about it. So you're welcome.
I'm gonna blast through the end here because we're getting close to the hour mark. The last one is people ask me about vasopressin all the time. Mm-hmm. So when they ask about vasopressin, I know that I've seen sometimes where people give push dose, vasopressin. Mm-hmm. I'm just talking about the drip, like putting them on a continuous vasopressin infusion. Most of you already know this. Your dosing for a GI bleed with vasopressin is different than really anything else. It's much, 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 much higher, much more concentrated. People often ask me why we don't do that. And I'd say this. It's because, one, we are a hospital that has quick access to a GI doctor at all times. Two is because that comes with huge risks. Mm-hmm. The two main risks being possibly causing myocardial infarction. So when you do dose at this high, for
That
perspective, right?
sounds kind of serious.
Yeah, your vasopressor dose is 0.01 to 0.04.
Right.
Your GI dose is 0.2.
Yeah.
All the way. You can go as high as 0.8 was what I learned. And that can not only cause you to have a heart attack, it can cause you to have bowel ischemia, all those things.
You know what I think of when you say that, and it's a bad analogy, but your normal BAC is like a driving limit is like at the 0.08.
I was going to say
right?
your normal BAC is 0.
Well, you know what I'm saying? Like what's deemed legal limit is 0.08.
Yeah.
And you know, that decimal never seems very important when you're talking about it, but then in the scope of like vasopressin, but if someone comes in with like a 0.4 BAC, you're like, damn.
Yeah. Yeah.
Same thing with the vasopressin.
Yeah. And we've covered this before. Vasopressin, the non-selective vasopressor activity on VO1 receptors and vascular smooth muscle results in intense vasoconstriction, which also affects the splenic arterioles. So, but like I said, the other thing, and I might have just said this. It's been a long morning already. If you do, for some reason, do this, you should consider starting nitro as well to kind of offload the heart a little bit. But those are the 4 drugs. Obviously, we've talked about definitive management is endoscopic therapy, whether that's...
Do you feel like if you need vasopressor support in addition to resuscitation, blood products, things like that in a GI bleed, are you starting vasopressin or are you just reaching for
I have done
levo?
it exactly one time.
Okay.
And that was when we suspected that the individual was actively hemorrhaging right now, right this minute.
Does vasopressin, I should know this, I'll be transparent on the cast that I can't recall it off the top of my head. Does it cause venoconstriction? I do not believe that it does, such as Levofed does, because there's my argument. You know, everyone always comes back to Levofed, but if you're in a hypovolemic state and you're trying to improve preload, you're giving fluid resuscitation, you've got these vasodilatory substances being released.
Yes, is the answer to your question.
It does. Okay.
Yes.
Then I know that one of the, proposed
Which that
improved mechanisms from Levo is the venoconstriction increased preload.
Well, I think that's part of it is when because with the nitro, right? Because your nitro is going to offset that and decrease your preload. Therefore, it's going to decrease the stress on your heart. Okay. Do you have anything else that you want to add? Obviously,
I do. I wanted to talk just briefly about NG or gastric access.
Good point.
In GI bleeds. So if you suspect that this is a ulcerative bleed, this is some type of peptic ulcer or upper GI source, they don't have a history of cirrhosis, they don't have a history of gastric varices, then by all means, we should be placing a OG or NG tube for decompression and just to keep sucking that stuff out of there, especially in the intubation period if this patient's going to need an airway, right? I wanted to take a little bit deeper dive on if that's indicated, contraindicated, or a gray area on people with a suspected variceal bleed or known varices. So I'm going to try to tread lightly when I state this right because we don't want to give any wrong. When I looked through this and listening to other critical care geniuses and podcasts and things like that, there is no guidelines that say that there is an absolute contraindication to placement of gastric access with someone with a suspected or even known variceal bleed or with varices, right? Mm-hmm. However, I think it goes without saying that you got to have just a little bit of street smarts about you, that if I have someone who has known varices, especially if they've had a history of a variceal bleed before, because we talked about rebleeds. So once, we should say that we had talked about it a little bit. So once you have I think anyone with esophageal varices has a 30% chance of bleed. Was that it? And then once you have a sentinel bleed, you're automatically at a 70% risk of rebleed, and that portends a poor mortality.
There was one that I looked at where the mortality was like 90%.
Yeah, it's bad.
Yeah.
So that being said, do I want to be shoving a tube down where I know that there's these big engorged varix that I could potentially poke and make bleed? No. But in the right clinical context, it's not completely contraindicated. My kind of argument towards placement is, say you have someone who has cirrhosis, you suspect that they have a variceal bleed, and they're already having massive GI hemorrhage, right? They're vomiting blood, they're having melanotic stool, that kind of stuff. You're trying to stabilize them, obtain an airway, and go that route. We've had the discussion about a contaminated airway and the elective esophageal intubation to control that bleeding, to kind of clear out the oropharynx and laryngopharynx, to have a visualization to tube that patient. If you have someone who's already bleeding, they haven't had endoscopic therapy yet, then in that point, I'm like, am I really going to make things worse? And would I be better off to place this NG-OG tube now, try and get some control of gastric outflow, aspiration, all that kind of stuff, try and clean up my view for intubation, place one beforehand, and then wait for endoscopic therapy. There is data out there that says that after endoscopic therapy, especially if, bands were placed, that you should avoid placing any type of NG-OG tube at that point in time, because you don't want to dislodge any band or clip or anything that's been done to achieve hemostasis previously.
Thank you.
You are welcome. If you are going to place a tube, smaller bore, more pliable tube is
tube.
Obviously going to be your best bet than sticking some, large diameter, rigid type of tube down there.
And not even just about, kind of having the control, being able to start feeding your patients who maybe are on like prolonged intubation, like maybe they're really sick, cirrhotic, and they're not going to get extubated anytime soon, blah, blah, blah. Those patients too need nutrition, There's some other things, we won't go down the road. If you're interested in that, there are bleeding score. There's a ton of bleeding scores. You talked about AIM-65. I was looking at the Forest grade, which is essentially like endoscopic evaluation. And the short version is, if you go in with a scope and you see an actively spurting artery, your rebleed risk is really high.
Well, and Rob makes fun of me because I did make a pretty detailed outline, but we're going to try and work on getting this stuff posted. So part of the reason that I do this is just, I would rather include more information, and Ron agrees with me. We just give each other a hard time so that it's there for you guys if you want it. And we talked about just the big points here, right? Like there's a lot of nuance that I put in here that we don't necessarily need to cover, but if you want to know about it, I listed some diagrams of the splanchnic venous outflow tract, so you can kind of understand that. In the portal hypertension, I listed a diagram, which you can Google all this stuff, just of the vascular anatomy of the celiac trunk. That's most often where IR is going to go and localize to embolize some type of bleeding artery from an upper GI source, is going to be from the celiac trunk. So we looked at that. Just quickly on lower GI, I just wanted to say that for the most part, we're not doing very much there except for the resuscitation, right? But gold standard is to get a CTA to try and identify the source of the bleed.
Write that down. If your patient is bleeding and you're going to go for a scan and you come back from a CT abdomen, I'm going to lose my mind.
CT abdo-pelvis.
Yeah. Well, I want the angio.
Oh, yeah. It's got to be with we need to see if there's extravasation of contrast. Yeah. If you don't see anything on a CTA, you can do a bleeding scan, which is a tagged red blood cell. And then you can see if you have any bleeding. I can't quote the exact flow rate, but you have to have a flow rate, like a certain severity of bleed. Like you have to be bleeding so much for you to be able to see that on a tagged RBC scan. So that may or may not elucidate any more information. And then the other thing about lower bleeds is like a gastroenterologist is not going to be as gung-ho about throwing a scope up through the rectum in a patient who hasn't had a bowel prep, that we're a little bit uncertain about the etiology for potential of causing worsening bleed, perforation, other complications. So you may see where they'll do like a rapid prep and try and scope them the next day. But for the most part, they're always going to start with an EGD, right? Yeah. And then they may just suggest that if they're not prepped and they're unstable, they may just say, send them for a CTA and see if this can be taken care of in IR or surgically before they do any type of lower colonoscopy.
Yeah. Yeah, remember, folks, if it comes out bright red, it probably came from below. If it came out dark, it probably came from above. And when I say that, I mean the ligament of treats.
Did you laugh at that in my thing?
I actually added it on mine.
Oh, okay.
Because I did go briefly down a little hole. I was like, well, what is it? Like, I know what it is, but like, it's like it attaches to the crura,
Yeah,
of
it's
your
what
diaphragm.
holds up.
And it attaches to your lumbar spine.
Yeah, okay, I'm with you. I know what it is. I got pimped on it during my surgical rotation. I was just trying to think of all the other stuff. Yeah.
Yeah, so that's it, yeah.
Well, yeah, I had a lot of other stuff, but you kept talking, so
I don't think that's the case.
we'll put it up. I listed just because it's, who doesn't love the arachidonic pathway? Arachidonic acid pathway. How NSAIDs cause
cyclooxygenase, COX-1. Anyway, we're well over an hour now. So yeah, this has been episode 23 of the Full Good Podcast. Obviously, go get yourself a shirt. Go get yourself a shirt. Go get yourself a mug. I'm not making any money on this. This is all.
buy one for your mom and dad.
Yeah,
for
they'll
your
love
kids.
it.
Do we have kid sizes?
There's a youth shirt.
Okay.
There is a youth shirt. I am. So my grandma, who she's got a little touch of the dementia. She was wearing her shirt and she was like, "This is the most comfortable thing I've ever worn in my life." And I was like, "That's fantastic." Then she leaves and comes back and slips me a 20. And I was like, "What's this?" She's like,
You're doing good work, Ron.
"For the shirt." I'm like, "God bless you." We're going places.
That's so cute.
But she was, so sweet about it. Check us out on the YouTube. Give us a subscribe, give us a follow. And then Clint, you want to do your little thing? Look right into the camera, which is now off kilter because you kicked it.
The slow, sultry.
Yeah. Buttery tones. That's going to be the next shirt. Buttery tones.
That's been episode 23 of the Full Code Podcast.
Yeah.
You guys know we appreciate you.
Yeah.
We're enjoying doing this. We love doing this. We're trying to put out.
Yeah.
We really do appreciate it. We like putting this stuff together. I like putting this stuff together. Ron likes
He puts none of it
doing
together.
all the work. You make me look so bad. The amount of times that I have offered, it's insane.
He offers, but I want it done on my timeline.
Yeah.
That ain't going to happen.
Dude, I'm always ready to go.
This will be done by the end of the day. He's going to go ride dirt bikes.
EOD.
There are two people.
That is true. I have
Inside me, there are two
11
wolves.
days in a row. Today's my first day off. Someone just came off of a stretch of days off. And
4 days off.
see how stupid he looks?
I get to leave early every day.
This is what I deal with on a daily
All right,
basis.
wrap it up.
So, yeah, Ron said all the things we want you to do. Email us at thefullcodepodcast.com.
Please like and subscribe. It really does help us out.
It really does help. I think we're excited. I'm not going to list the numbers because it sounds silly when I say it out loud to other people, but we have personal goals. It took us a little while to surpass our first goal of total listens, but we see the growth. It took us probably 7 months to attain our first goal, and then the growth has been exponential. So in the last 3 months, we've kind of doubled what we did in the first 7. So share it with your friends, share it with your colleagues, nursing school students, PA students, MP students. We're here to try and provide great clinical context, good clinical pearls, also with good banter and in a easy, digestible manner that's not so just, study and academia based. So we hope you guys like it.
Like you said, it's been pretty dramatic the last couple months. I'm humbled by it. It's so awesome for all the support. It's really fun to get to do this. And
it's been encouraging to us because, it does take a lot of work. We've been at this for over a year now, and we try and put out an episode every 2 weeks. I mean, once we finish an episode, I start researching the next one, so
start talking to people.
It kind of goes a little bit under the radar, especially all the work that Ron's doing. He knows I appreciate him to make this happen. So to see the growth has been exciting, and we hope to just keep it coming. So like and subscribe.
Yep.
All right.
Thanks, everybody.
Later.